This explainer is based on Motion Sickness Susceptibility, a Vestibular Physician's Deep Review of Neural Mechanisms, Clinical Assessment and Therapeutic Management, published by Australian Dizziness Clinics.
Welcome to the sixth and final explainer in our Vestibular Physician series. Today, we are diving into cybersickness, special populations, and future directions.
Here's a quick look at our agenda. We're going to cover the rise of cybersickness, the VR rehab paradox, managing special populations, a really cool phenomenon called paradoxical immunity, and finally, frontiers in treatment. Let's get right into it.
Section 1. The Rise of Cybersickness. You know, the screen era has completely flipped the landscape of motion sickness on its head. Think about our modern triggers: scrolling on smartphones, sitting in wide-field IMAX cinemas, flight simulators, and of course, VR headsets. Modern tech has essentially inverted traditional motion sickness. It's created what we call sensory conflict reversed. Instead of your vestibular system feeling motion while your eyes see a stationary environment, optic flow is telling your brain, hey, we're moving at warp speed, all while your inner ear remains perfectly, completely still.
In the fallout from this, it's absolutely massive. To put it in perspective, a staggering 80% of people feel sick the very first time they put on a virtual reality headset. 80%. And to make matters worse, half of those users just abandon the session within 20 minutes because the symptoms are just too overwhelming. Visually induced motion sickness, or VIMS, well, it's no longer just some niche issue. It is a dominant clinical presentation.
Which leads us directly into Section 2, the VR-rehabilitation paradox.
Here is the incredibly frustrating clinical dilemma we're all facing. On one hand, we have patients who desperately need vestibular rehabilitation. But on the other hand, these exact same patients have a massively high susceptibility to VR-induced sickness. So the very people who need that immersive exposure the most are the exact ones the tech makes the sickest. It is a huge, frustrating barrier to graded exposure therapies.
When a patient drops into immersive VR, the headset delivers incredibly compelling visual motion. We're talking really strong optic flow. But there is absolutely zero corresponding vestibular input. Because of this mismatch, we can't just throw a headset on a sensitive patient and cross our fingers. Doing that basically guarantees the session is going to fail. We have to be highly, highly strategic.
So what's the fix? It's what we call a desensitization ladder. You've got to establish habituation on a standard, flat 2D monitor first. Think slow scrolls and horizontal movements. Only after they absolutely conquer 2D optic flow do you introduce active head movements. And only then, actually, scratch that, only strictly then do we ever graduate that patient to a fully immersive VR headset. Furthermore, recent 2024 data from Gannon and colleagues confirms a really critical protocol update. Multiple short VR exposures, spaced by 2-hour intervals, actually update the brain's internal sensory model way better than a single, long-endurance session. Pushing a patient to just tough it out for a long VR session? Totally counterproductive. Short, spaced intervals are the absolute key to adaptation here.
So building this into a complete vestibular physician pathway means assessing their baseline with the VIMS-SQ short score, pinning down any underlying vestibular diagnosis, and then deploying that graded optokinetic desensitization program. Your ultimate goal line? Getting the patient to 20 sustained minutes in VR with zero symptoms. That is the gold standard.
All right, moving on to Section 3, managing special populations.
Now, I highly recommend taking a mental screenshot of this matrix. It is literally your clinical cheat sheet for mapping specialized populations against some very strict pharmacological safety profiles. Because when it comes to prescribing for motion sickness, one size absolutely does not fit all. Let's break these down group by group.
First up, pregnancy. First trimester pregnancy dramatically amplifies motion sickness susceptibility. This happens because HCG and estrogen are basically hypersensitizing the area postrema, which is the brain's emetic center. For pregnant patients, your preferred go-to agents are dimenhydrinate, cyclazine, or just 1 to 2 grams of ginger, which is incredibly well tolerated. You absolutely must avoid category C anticholinergics like scopolamine or promethazine during that first trimester. No exceptions.
Next, we have our elderly patients, and they present a really fascinating physiological shift. You see, patients over 65 are paradoxically less susceptible to motion sickness. Why? Well, it's likely due to the physiologic shortening of the velocity storage time constant as we get older. It just naturally winds down. But if an older patient does happen to present with symptoms, you need to be super careful.
Avoid medications on the Beers criteria list, like scopolamine or diphenhydramine, because of their anticholinergic, cognitive, and cardiovascular burden. Instead, opt for something like cynarazine or cyclazine.
And then we have our occupational contexts, like commercial aircrew and military personnel. Get this, baseline susceptibility causes a 28 to 60% attrition rate in naval aviation candidates. It's a huge hurdle. And for commercial flight crews, your pharmacology options are completely grounded by civil aviation regulations. Literally 0 sedating medications are allowed while on duty. So what do? Rigorous, non-pharmacological graded habituation is the absolute only authorized pathway you've got for this population.
Section 4. Paradoxical immunity. Speaking of unique responses, this is an incredible clinical pearl. Patients with complete bilateral vestibulopathy, meaning absolute, total labyrinthian loss, they actually have a paradoxical immunity to classical physical motion sickness. Because their velocity storage signal is completely abolished, they literally cannot get seasick. There's no way. But you still need to counsel them carefully. Because they have intact cortical processing of optic flow, they can absolutely still suffer from cybersickness and VIMS. So always make sure to assess them for visually induced sickness independently.
Finally, Section 5, Frontiers in MSS Treatment.
Let's turn our attention to the research horizon and see exactly where this field is heading. There are 3 major innovations positioned to dramatically change how we quantify and treat motion sickness over the coming decade. We're talking neuromodulation, advanced pharmacology, and ecological tracking. First step is cerebellar TDCS, or transcranial direct current stimulation. Remember how the velocity storage mechanism prolongs motion sickness? Well, early phase 1 studies are showing that applying non-invasive TDCS directly over the nodulus of the cerebellum can effectively dampen and shorten that velocity storage. This is a very credible investigational treatment. It could literally rescue patients from severe refractory cybersickness by artificially shortening their internal motion persistence. How cool is that? Simultaneously, we're keeping a very close eye on the CGRP pathway. Anti-CGRP monoclonal antibodies are currently being investigated for their secondary benefits, specifically lowering trait susceptibility in vestibular migraine patients during the times between their headache attacks. And over on the hardware side, wearable AI technology. Head sensors tracking kinematics, heart rate, and eye movement are preparing to move our assessments entirely out of the clinic. We're talking continuous, real-world measurement of a patient's exact symptom burden as they go about their day.
So, as we wrap up this entire Vestibular Physician series, let's summarize today's big takeaways. Cybersickness is the new dominant presentation, period. To treat it, you absolutely must systematically graduate your VR rehab patients using a 2D to VR ladder, utilizing short, spaced intervals. Always, always tailor your pharmacological prescriptions precisely based on a patient's age, pregnancy status, and occupation. And finally, get ready for a highly technological future driven by neuromodulation and AI wearables.
This has been an Australian Dizziness Clinics Vestibular Physician Review. Visit AustralianDizzinessClinics.com to access the full literature review and download that clinical cheat sheet we talked about. I want to leave you with this final thought. As we stand right on the brink of wearable AI and real-time neuromodulation, how will the very definition of a clinical visit change when our headsets and sensors know we're getting sick before we even consciously feel it? Thanks for joining me for this explainer, and keep learning.